Let's talk about adhesion for the direct or indirect restoration. We all know the etching procedure before the bonding step, and there are three different etching procedure for the restorations before the restoration. The first one that we all know, total etch, which we etch the dentin and enamel at the same time. And the other one, after introducing of the sixth and seventh self-etch system bonding agents into the market, the self-etching is the other way to without phosphoric acid, and the other method is the selective etch, which is a very good way, especially for the deep caries, because if we etch the enamel surface, the literature shows that you can get higher shear bond strength by etching the enamel surface, even if you don't etch the dentin surface. But we can just use that both method, self and selective etching, with the only self-etching bonding system. So, so I want to show you the total etching. There's a smear layer on the dentin surface, and when we are etching, we directly cover the smear layer, but the maximum etching time for the dentin surface is 15 seconds. The maximum one. We shouldn't exceed the 15 seconds. When it comes to enamel surface, we are a bit comfortable when etching the enamel surface. For intact enamel surface, we should etch 30 seconds, but or more. But literature tell that there is no difference between 30 seconds and 60 seconds. When it comes to for cut enamel surface, the prepared enamel surface, there isn't any aprismatic enamel surface. It's enough etching the surface 15 seconds. For the primary tooth enamel, intact primary tooth enamel, for example, especially the intact means, for example, when we are closing the diastema, when we are doing the diastema restorations on the anterior tooth, anterior teeth, anterior region, for the adult patients, adult teeth, the permanent teeth, we can etch the enamel surface 30 seconds. But for the primary tooth enamel, we should etch the primary tooth surface 60 seconds, because the mineral ratio is different when you compare with the primary tooth with the permanent tooth. So for the primary one, we use 60 seconds. Well, it is the self-etching method. I am etching the enamel surface very slowly, and you should be careful on the bottom of the cavity line, because uh, it doesn't create very big problem if you are etching on the dentin enamel junction, but especially for the deep caries, it may be a problem to etch the deep dentinal area, because it may create a bit post-op sensitivity. The other section is rinsing. The rinsing is the other important method for the etching process. And on the rinsing step, you can directly remove the phosphoric acid, and the collagen fibrils show up. And the rinsing, We should rinse for 30 seconds, and we should be careful when you apply matrix band, especially automatic system, the circumferential system. They sometimes they sometimes avoid reaching of water nearby the matrix tooth contact surface, and we should turn around the tooth surface with a water syringe when rinsing to clean the phosphoric acid totally. And for the drying, we need the literature show that we should use wet bonding to the dental surface. But how wet? When you think about the seaside, there is three different wet level. The first one is the sea, the wet level. The second one is the moist, the sand nearby the coast, and the other one is the dry, far away from the seaside. So, how wet we need for the good adhesion? For the dentin surface, we have collagen fibrils, and the collagen fibrils like a human hair. And you know, when we have moist or wet hair, it has like a electricity looking, and after drying, our hair collapse directly. The dentin surface is similar. If you dry them a lot, you may collapse the dentin surface, the collagen fibrils on the dentin surface. And when you compare the left side photo and the right sided photo, on the left sided photo, it's very easy to make uh, adhesion on the irregular surface. Because on the right side, when you apply the adhesion, it like the slide on the dental surface, and there wasn't any irregularity for the adhesive to stick on. So that's the reason why we want wet dental surface, because when the moisture uh, decrease, the wettability is decreased as well. It's the adhesion step. That's the bonding step, and it's directly filling the gaps in the irregular area between the collagen fibrils. And for the adhesion area, we must be careful when applying the adhesives because we need high quality hybrid layer, and that hybrid layer contains different layers such as collagen fibrils, such as bonding agents, such as smear layers. And if we have a good quality hybrid layer, we can decrease the micro leakage, postoperative sensitivity, and secondary caries risk as well. And with the high quality hybrid layer, we can directly increase our adhesion. And the adhesive application, it depends what system you are using. I can't tell you that you should rub the 10 seconds or the 20 seconds. It totally depends on the adhesive system, and follow the prescription of the system because each brand suggests different application. For example, some brands suggest that you can just leave the adhesive for the 10 seconds, then use the air blow and cure it. The other brand may suggest that you must rub the adhesive on the dental surface for 10 or 20 seconds. But it mostly, I can tell that mostly it's suggested rubbing for adhesive on the dental surface between 10 and 20 seconds. And that's how we are rubbing the tooth. After etching, I'm rubbing on the dental surface. for the 20 seconds, and then I'm making thin the adhesive layer and curing what the company, what the material are being suggested. So in the clinical practice, especially for the deep caries, we can use different methods to protect the deep dentin area because you can etch the dentin surface, the enamel surface, more than 15 seconds, like 30 seconds, 45 seconds, but it's very difficult to make it for the dentin surface, and it's very dangerous because the patients may encounter with the postoperative sensitivity because of the overetching. So in clinical practice, I am protecting the deep dentin area by using the cotton. And for the etching process, I can directly etch the surface. Then I am cleaning it again. And I'm changing it again because there are some acid remainings, especially for you can directly remove the former cotton and you can directly clean and rinse the cavity. But before the drying step, it's better to place there a different cotton again, and you can directly dry the air below the cavity surface. Then you can apply your adhesive application. The other important point is for the adhesion, we must have different size micro applicator because especially for the minimal invasive dentistry, if we want to protect the more tooth tissue, we must have very small tips, from very small tips to root canal post tips for the adhesive application. For example, this patient has very small proximal caries, and for that caries, we must use magnification like a microscope or dental loops. But the most important thing, we must use very small tip, small head micro applicators to reach all the dentin surface. Otherwise, you can't touch the dentin surface. Even if you are using small micro applicators, sometimes it's very difficult to reach very thin areas. And also, if you are using low quality micro applicators, the hair of the micro applicators may shed on the cavity surface. So you can directly, you must have high quality the well-known brands micro applicator brush. And other way is using the micro brush as well. They have different small brush tips, and especially for the very small cavities, for the diastema closure, for example, I was planning to close the diastema on the mesial side of right central tooth. It was very difficult to reach that point by just using normal micro applicators. Here, the brushes are very useful to reach the proximal area. Well, you all know we have different generation for the adhesives. The fourth generation, 5, 6, 7. I don't want to make you really. I don't want to make it very complicated. I don't want to make you bored by explaining the generation of the adhesion, but I can tell you after increasing of the generation, mostly the number of steps are decreasing. For example, for the fourth generation, we were using three different steps. For the fifth generation, it's two. For sixth generation, it's still two, but they are after sixth generation, they are starting. The companies are introduced the self-fetching systems, and with the sixth generation, uh, we don't need to etch the dentin surface. And seventh generation is they mix the primer and bone at the one bottle, and it's one bottle system. But for the sixth and seventh generation, we shouldn't etch the dentin. Otherwise, the plug, the void, the after phosphoric acid, they remove the smear layer, and these adhesives cannot fill the that voids perfectly, and the patients may feel postoperative sensitivity, especially for the deep dentin caries. So for sixth and seventh generation, we shouldn't etch the dentin surface. After that, the companies introduced universal system, or also seventh generation, but they also called as universal system. For the universal system, you can etch the dentin as well, or non-etch the dentin, but you still need to etch the enamel surface. And before the restorations, we should have very good quality adhesive layer for the application of composites. Now, how we are doing the restorations, and what kind of material we can prefer for the restorations, let's talk about it. We have different flowability and viscosity composites. For the bulk fill composites, we can directly use it for the dentin layer, for covering the to cover the dentin surface. For fiber reinforced composites, especially for deep dentin caries, we can use fiber reinforced composites. They have flowable one and bulk fill one. Sorry, they have flowable one and condensable one, and also bulk fill one and dentin composite, which has different chromas. And I'm closing the dentin layer here. The other one is high filler content flowable composites, and now some companies are producing high filler content flowable composites for the direct posterior or anterior restorations, and especially for that kind of small cavities, these flowable composites, the injectable composites, are very useful. And then you can make the occlusal anatomy by using its tips and then flow it. And the other one, which we all know, paste type composites. And paste type composites are very useful handling, and we can shape it by using hand instruments. When you compare with the flowable one and paste type composites, they are more enjoyable composites, because you can give shape them by using the dental brush, or also some other instrument like a root canal file and the files, or some small needle hand instruments. Here you can directly add more composite with the incremental method, and by the help of the brush, you can shape and condense it. And here you can give anatomy by using the brush. They are brush for the art. You can use them for the dentistry, but you must use their small tips, very small thin tips. And also it's a file and the file micro opener. And again, you can use your brush on the final step to create smoother transitions. Otherwise, the end of files create a bit irregular surface, and after on using the brush on the last step, smooth that irregular areas. So we have different composites in the market, and it's classified depends on the functional capability based, like a bioactive geomer, fiber reinforced, low shrinkage, Ormosar, bulk fill, siloron, infiltration resin, compomer, self-adhesive. There are lots of different composites and particle size based. I don't want to bore you about lots of theoretic knowledge, but before I show something, I want to tell how can we classify composites, microfield nanocomposites, and rhizometric space like a metaclad or Mosero geomer, and restorative procedure based like a direct composite or indirect composite for the dental technicians, or if you are doing indirect restorations in your clinic, and filler type shape based, nanoceramic, spherical, nanocluster. Every companies have the different feature for their composites. And curing mode, self-cured, light cured, do all heat cure, and viscosity based, condensable and flowable one, and shape based classification, monochromatic, bichromatic, or polychromatic composites. Let's talk about the other classification. The classification based on the chroma is the most popular one now. So we have the color with the three different parameters. The first one is hue, and it refers the name of the color, like a red, yellow, green, or navy, or another. And the second parameter is the chroma. Chroma refers the density of the color. You can you can think about the young patient and old patient, and the elder patient mostly have the chromatic color because of the mineralization of the other reasons, other chains on the tooth. So we can we mostly select the darker colors for the elder patients. There are two main reasons for the changing chroma with age. Why does the chroma increase with age? There are two different main reasons. The first one is the artificial reasons, the consuming of the coffee, tea, or other colorful meals or beverages. And we solve that by using bleaching. We solve that discoloration by using bleaching. There's a double bonded chromophore on the dental surface because of the related to that materials. And the oxidized bleaching agents break directly these double bonded, and the chromophores, the color of the chain, the color of the tooth, directly change from yellowish to a bit transparent. So we can solve the chroma, we can brighten the chroma of the tooth by using bleaching. The other reason is the physiological reason. There's an intratubular dentin on the surface, on the tooth surface inside the tooth, and that intertubular dentin include minerals, collagen, and non-collagen proteins, liquid, and collagen fibrils. And the collagen fibrils, is the main and the most important thing for the good adhesion. And there are some voids on the intertubular dentin, and there is the intratubular dentin inside that gaps, that voids, and the collagen fibrils is lower than the intertubular dentin, and there's a odontoblastic process inside that intratubular dentin, and in time, the mineralization occurs with age, with some change, with some physiological change. That mineralization makes it possible sometimes working without anesthesia because they also avoid the transmitting of the heat temperature change. Like when you are working on the, even if you are working on the deep dentin caries, just because of that mineralization, the patient may not, especially for the older patients, they may not feel any sensitivity during the preparation process just because of the that mineralization. But they also change the of the color of the teeth, and after some mineralization, the tooth looks more yellowish. The other parameter is the value, and it decreases with age. And value refers the light opacity of the color and the light transmittance or light reflections of the material. If a material transmit the light, it will shown like a transparent material, like a enamel color, like a glass. But if the material reflect the light, that time, this time, this material looks more opaque, and that kind of opaque colors has the higher values. So we all know opaque body and enamel composites from the composite scale. And for the opaque composite, we mostly use that for the hiding the fracture line, hiding the amalgam mercury filling discoloration, because we directly hide something by using opaque composite. There are six same balls inside the glasses, and when you compare uh, the view of the glass, when you decrease the value, you can see the ball easily. It's same for the composites. If you want to hide something, you must use opaque composite. Or you can use body composites if you are planning to close diastema, if you are planning to do direct posterior restorations. They don't have a they don't have opportunity. They can't hide the fracture line like opaque composite, but you can use them for the diastema restorations. When it comes to enamel composites, they are more transparent than the other two composite type, two value type. So we can create the mamelon effects, we can create the halo effects by using enamel composites, but we must be careful when you are using transparent shades because sometimes if you use the enamel shades more than normal, you may encounter with the grayish restoration, and the grayish restoration means lower value restorations. So when you decrease the value, the restoration looks more grayish. But why does the value decrease with age? There's a this time it's related to enamel layer. There is a hydroxyapatite crystals enamel rods on the tooth surface and also a prismatic layer on the enamel surface. And when you look into the enamel structure, there's a hydroxyapatite crystals, and for the young patients, the mineral content is lower than the elder patients, but the water and protein content is higher than the all the elder patients. So it directly affect the color of the color of the tooth because when you decrease the water and protein content, the tooth or the any material cannot refract the light uh, refract the light like a young teeth, and the lower water also creates the lower fracture resistance of the tooth, especially for the mature patients. We must be careful when we are diagnosing or when we are making indication, when we are doing planning for their restorations, because for the mature enamel, we shouldn't leave a very thin layer of enamel tissue because it's more fragile when you compare with the young patient's enamel layer, and it may directly change your diagnosis. And that patient, on the left-sided photo, the patient is 25, and the right-sided photo, the patient age was 68. When you look up the incisal of the restorations, the right side enamel looks more transparent when you compare it to the left side because there's an enamel wearing and there's an increased dental mineralization, and it directly changed the chroma, changed the color of the tooth. And the right side, you are seeing more yellowish color just because of the chromatic change and maybe related to mineralization and also some artificial reasons like beverage or meals. And after that, you know, the enamel structure content water. And when we are doing direct or indirect restorations, especially if we are working under rubber dam isolation, we directly dry the enamel surface, and it directly change the color or reflection feature of the enamel layer, and the tooth looks more opaque, more brightened than the beginning of the patient. So that's the reason why we should call or follow up our patients after 1 week, because it's the top one shows that the initial of the patient, and the final one on the bottom one shows the immediately after restoration, and the restoration line looks the tooth looks more brightened and the restoration looks more yellowish. So if we directly think that, oh my God, I must change my restoration color because it looks more yellowish. So when the patient come to follow-up session, that time you will see brightened or whitish restoration. So to check the restoration color, I mostly prefer to follow up my patient after 1 week at least, after 1 week at least. And that's just after 1 week. I didn't do anything, just the enamel layer rehydrated again. So when we are checking the color, it is better to check check it after 1 week. So when we are restoring the posterior restorations, we have three different ways. The first one is the monochromatic layer. Just you can restore the restoration by using body shade composites, and you can use the same color flowable one, and you can finish the same body shade composite. The other method, you can use more chromatic flowable composites on the dentin surface, and after that you can use the body shade composite for the to create the occlusal anatomy. But I mostly prefer flowable composites on the bottom line to cover the dentin surface because of their viscosity. They can directly close the dentin surface. Their viscosity totally different when you compare with the condensable one. The last method is the polychromatic layering method. You can use the flowable composite. Then you can use especially for the deep caries, you can do that. But for the shallow caries, for the shallow cavities, it's very difficult to use different colors. To be honest, I mostly prefer working with the body shades. I rarely use dentin, enamel, and different colors and some makeup colors. Actually, it is depends on you, but if you are using the polychromatic layer, you can cover the dentin layer firstly flowable composite, then dentin or opaque shade, and you can finalize your restoration by using enamel or translucent shade. That is the viscosity of the composites. If you have, we all know viscosity, and if you want to cover the small irregular areas, you must use low viscosity material. So the left side, you are seeing low viscosity material. It's like to fill all the wall of the surface. But when it comes to right side, it directly stay on the area, on the location where you put it. And after that, we need to make our occlusal restoration after creating the base. So for the morphology, we can use different materials like a needle, hand instruments, brush, endophiles, and some other different materials. For brushing, you can directly sculpt the condensable composites. You can also use endophiles to create the fissures, and you can also use needle-headed hand instrument to create the fissures as well. And it's the other version. And the big head hand instruments are very useful to condense the composites. So let's talk about the morphology more. Actually, for the creating the occlusal fissures, I mostly prefer endophiles or thin head sable brush, and also needle head hand instruments. And when it comes to proximal area, I am using that kind of instruments to condense the material, and the top one is very useful to create the proximal height of restoration, because here you can use it with the here you can uh, use it to decide the height of the composites. And for the marginal area, I'm using a bit wider hand instrument and wider brush. And in that step, I mostly prefer to finalize the sable brush to finish the restoration. The using of brush, the needle point brush are very useful when shaping the fissures, and especially for the small cavities, we can directly work with that brush without any other hand instrument. And the right side, you can see the white hat brush, and it is very useful for the anterior restorations. Like, for example, when you are doing composite veneers, it is very useful. But for the posterior area, it's very difficult to use it on the proximal area when you are adapting or condensing the composite to the proximal side, or condensing it to the matrix band. So you can use it for the marginal area on the occlusal area, or the buccal area when you are making class 5 restorations.